I'm going to give the first talk, kind of lead off with a 15-minute talk on difficult issues with non-muscle invasive bladder cancer guidelines, and just kind of selectively pick some things from the guidelines that I think would be good teaching points and focus areas. So I don't have any COIs related to this particular topic, so go ahead and get that out of the way. So what do we hope to accomplish here? We're going to talk about variant histology and risk stratification. So that's one area that is a particular focus in the updated guidelines. Understanding risk stratification is important not only for predicting recurrence and progression, but also in managing patients based on treatment, duration of treatment, et cetera. And then we're also going to talk about how failure to sort of adhere to some of these guidelines could result in not only understaging, delay in treatment, under treatment, and obviously that can impact on patient outcome. So the areas that we'll focus on in the short time that we have for this will be the variant histology and the AUA's risk stratification for non-muscle invasive disease. We're going to talk about who to repeat the TUR on versus going straight to treatment. We're going to talk a little bit about perioperative chemotherapy, which is highly underutilized in the United States. And then when we do decide to do maintenance therapy, what's the duration and who should get a year, who should get longer than a year. And then we'll talk about some of the newer technologies for enhanced detection. When it comes to recurrence and progression, we know that tumor stage and tumor grade are important contributors to this. And this is just from the EAU, and it shows that clearly as the stage goes from TA to T1, there's a higher risk, not just of recurrence, but of progression to muscle invasion. And then we know that all high-grade tumors have a higher risk of not only recurrence, but progression. But some of the models that are out there, so the EORTC and the Spanish group also have, there's other web-based models for calculating based on traditional factors like size of the tumor, number of tumor, grade, et cetera. The AUA SUO editions included things like lymphovascular invasion, whether or not there was involvement of the prostatic urethra, the variant histology, and prior response to BCG therapy. So this is the AUA SUO guidelines that are listed here. There's not a lot to remember for low risk. The low malignant potential tumors, which are relatively uncommon, and then the solitary small TA tumors are in that low risk category. For the high risk category, you can see high grade T1, any recurrent high grade TA, CIS, patients that have had previous BCG therapy and failed, variant histology, presence of lymphovascular invasion, and prostatic urethral involvement. It's not a perfect categorization system though. You could debate looking at different things. The box I've highlighted here, a low-grade T1, we wonder if that really should happen. I've had a few patients that's what they claim, but most people consider T1 tumors to be high-grade, high risk. If you had a very small low-grade but 2 tumors, could you still be low risk? Those are certainly possible. And for TA tumors that are high-grade, drawing the line at 3 centimeters or so is maybe not perfect either. So it's not a perfect risk strata system, but at least it gives you a framework to work in when you're trying to come up with recommendations for treatment. In terms of variant histology, this is becoming more and more common. We used to say these are relatively rare, small percent of the tumors, but we're seeing versions of these variations show up on many path reports now. It's recommended that if you're going to do any form of bladder sparing, that not only do you have that reviewed first, but also restage them, because you don't want to have an invasive tumor go on to get a bladder preservation strategy. They might have needed a lot more done. This is sort of a review of what's out there for the variant histologies, but up to 25% of cases have some version of this. We know there's discordance between the TUR and the cystectomy in many cases, and these are difficult for a general pathologist, somebody that's not doing urologic pathology every day, to really categorize. And you can see that there's certain types, such as the lymphoepithelial, the plasmacytoid, nested variant, that are particularly problematic for them. And that's why it's reasonable to get a reference or a second opinion pathology so you know that you're off to the right start. Why all the talk about it? Because these patients many times can be associated with a worse prognosis. We know they can have more locally advanced tumor, more invasive tumor, nodal involvement, 3 times more likely to have, upstaging on their cystectomy. And they have variable responses to chemotherapy, intravesical therapies, etc. To show some of the confusion in this, small series of usually done for these type of patients, but this was an MD Anderson series where they showed that upfront cystectomy was more effective than BCG for patients with micropapillary variant. Here's a contra statement from Memorial Sloan Kettering, another small series, but in patients who had micropapillary variant, underwent restaging TUR, and they actually did about the same as those patients who had a cystectomy. So they concluded that conservative management may be appropriate. Here is some work from the genomic work in bladder cancer, where they looked at micropapillary and found that these tumors are more likely to behave like luminal tumors or even P53 variant, which we know can be more resistant to cisplatin-based chemotherapy, conventional neoadjuvant chemotherapy, and probably also in some cases resistant to the intravesical therapies that we give too. So we don't really have a great way currently to know which micropapillary variant we're seeing in the office, and so this may explain, at least in part, why we have this disparity. The guidelines recommend a repeat TUR for certain circumstances. I think everyone would understand if it was a very large tumor, too much tumor burden to get in one setting, you'd go back and resect for an incompletely resected tumor. But what about the high-grade TA tumors? They didn't say there's not enough data to mandate that you definitely need to do it, but it's strongly recommended. So for high-grade TAs, and then the consensus is that for T1 tumors, if you're contemplating bladder preservation, you should go back and rebiopsy, re-TUR the scar, make sure that you don't have a muscle-invasive tumor before you move on to intravesical therapy. This was a randomized study, small number, I think a couple hundred, 200 patients, but it did show that in those patients who underwent that repeat resection, they had significantly better outcomes in terms of less recurrences, because you did a better job probably up front. And then that translated into reduced risks of progression. The second TUR alone was beneficial. So those both emphasize that not only does this exercise help to ferret out which patients need to move on to more aggressive therapy, but it impacts on their long-term outcome for bladder preservation as well. So just summarize, we know that in patients that have incompletely resected, high-grade TA, and any T1 or variant histology in whom bladder preservation is being contemplated, those patients should undergo repeat evaluation. What about single instillation perioperative chemotherapy? It's recommended for low risk and maybe intermediate risk patients as a single postoperative installation at the time of TUR. We would not want to do that if we had an extensive resection, bladder perforation, or sort of a lot of postoperative bleeding. Those sort of things would shy you away from doing that. But in an ordinary circumstance, you'd like to offer these patients single shot perioperative chemo. This was the AUA guidelines where they looked at, on a forest plot data. Most of this data is derived from European studies, not necessarily US, but there were benefits in terms of reduced recurrence rates in patients with just a single installation in that perioperative period. The caveats when they looked at this were mitomycin or epirubicin were usually the two most commonly utilized agents. Try to get a dwell time of about 2 hours. Administer within 24 hours of the TUR, which can be a logistical problem for many patients depending on where they're having their procedure done in the United States. And then selecting patients that are the right patients with that low risk feature. Side effects, which are largely driven by mitomycin, are included here, but dysuria, lower urinary tract symptoms. Sometimes patients can develop dystrophic calcifications, and these can be problematic if you're not used to seeing them, and you might feel compelled to resect them or do more to them. Most of the time, if it's done appropriately and avoid those patients with perforation, it can be well tolerated. Last year, the SWOG study looked at, this was, lead author was Dr. Messing, but they looked at the perioperative use of gemcitabine in the same setting, again, using similar profiles, low-risk patients, presumably. Interestingly, they didn't always get it right. In fact, only about 40% of the time, there were more high-grade tumors or worse pathology, but I'm sure they were also kind of biased by motivated to enroll patients in the study. But the patients got randomized. They either got 2 grams of gemcitabine or normal saline, and then they underwent their follow-up. And there was a significant reduction in the time to recurrence in the patient that had saline, more likely to recur, and that was about a 50% recurrence reduction with the use of gemcitabine. It was well tolerated. They really didn't see the type of feared complications, if we will, with the mitomycin that were used. And it looks like it's probably replaced, for many of us who do this, the use of mitomycin in the office. The gemcitabine is also significantly lower in cost than mitomycin, so that's another good reason to consider it. So what about intravesical therapy in the guidelines? For low-risk patients, that perioperative single shot is recommended, but not recommended to do longer therapy for the truly low risk. For the intermediate risk, you really have a dealer's choice. You can either do chemotherapy or BCG, and then for the high-risk patients, it's recommended to do BCG induction. And so what about maintenance in these groups? For intermediate risk, if they're responding well to their chemo, you can continue the chemotherapy, usually for a year, and that's usually monthly in the United States. What about BCG? Usually, if it's intermediate risk, they get 1 year as recommended, and for high-risk patients, longer, 2 or up to 3 years is recommended based on data from the guidelines. We have a separate talk later on narrowband imaging and fluorescent cystoscopy from Neil Shore, so I won't go too far into that except to say it is in the guidelines now. Many of us are familiar with the Olympus technology that's used to evaluate and enhance the vision of traditional white light with the use of this, and the data is not as robust perhaps as for the Cysview, but it is showing that there's enhanced detection and there are more tumors seen in any one patient with the use of narrowband. Blue light is also in the guidelines now for the use of Cysview, and this will be elaborated on much more in the standalone talk, but we know that the Cysview gets into the tumors much more preferentially than regular bladder mucosa. It does require some equipment and the Cysview product itself, and then it has translated into not just enhanced detection, but a reduction in recurrence. So that's shown there. So the take-home messages from this first talk are the importance of risk stratification. You should do that in patients when you diagnose them. The value of a repeat TUR for the situations that I highlighted. Encourage the use of single shot perioperative gemcitabine chemotherapy. The use of maintenance therapy, 1 year for intermediate, 3 years for the higher risk patients, and then judicious use of the enhanced technology to find more tumors early and reduce the recurrence rates independent of their intravesical therapy.